Monteggia fracture dislocations and equivalents. Still problem for parents and orthopedic surgeons. The Monteggia injury was initially described in a case report by Giovanni Monteggia as a proximal third ulnar fracture associated with a radial head dislocation. Subsequent studies in children have demonstrated that this injury differs significantly in the skeletally immature. Bardo 1967, Boyd and Bowles 1969, Mullick 1977, Speed and Boyd 1940. In children, the peak incidence is between 4 and 10 years of age and encompasses about 1% of all forearm fractures. It is typically sustained after a fall onto the outstretched hand resulting in a hyperextension or hyperpronation load onto the elbow, K and Skaggs 1998. Latanza LL, Chen S. 2014, Monteggia fracture dislocations. In, Abzug J, Kozin S, Zlotolo D. eds. The Pediatric Upper Extremity. Springer, New York, New York. Latanza LL, Chen S. 2014, Monteggia fracture dislocations. In, Abzug J, Kozin S, Zlotolo D. Edition. The Pediatric Upper Extremity. Springer, New York. The eponym Monteggia fracture became commonly used after it was described by Bardo with reference to the original case report by Monteggia, Bardo 1967. It was recognized that the ulnar fracture did not always occur at the proximal third of the ulnar as originally described. The Monteggia fracture eponym evolved to encompass any fracture of the ulnar with a radial head dislocation. The Monteggia fracture is now commonly used to describe a radiocapitellar subluxation or dislocation with an associated ulnar fracture or deformation. An ulnar fracture with an associated radial neck fracture is commonly referred to as a Monteggia equivalent. Monteggia fractures in the pediatric population can result in excellent outcomes if recognized early and treated promptly. Reduction of the fracture or deformity of the ulnar usually results in reduction of the radial head. However, the chronically dislocated radial head from delayed recognition results in a more difficult injury and treatment strategy. It is important to promptly recognize the Monteggia injury to avoid an unacceptable outcome. A Monteggia fracture dislocation consists of an ulnar fracture or deformation with radial-sided ligament failure and subsequent radial head subluxation or dislocation. The forearm consists of the radius and ulnar with three strong stabilizing ligamentous connections: the distal radio-ulnar joint, the central interosseous membrane, and the proximal radio-ulnar joint. The proximal joint is stabilized by the quadrate ligament, radial collateral ligament, and elbow capsule. The radial head maintains congruency within the proximal radio-ulnar joint with contribution from the annular ligament. Both the proximal and distal radio-ulnar joints provide rotational movement between these two bones. The proximal joint is stabilized by the quadrate ligament, radial collateral ligament, and elbow capsule. The radial head maintains congruency within the proximal radio-ulnar joint with contribution from the annular ligament. Both the proximal and distal radio-ulnar joints provide rotational movement between these two bones. Therefore, any injury to the bony or ligamentous structures will hinder pronation and supination of the forearm and may result in a post-traumatic arthrosis at either articular surface. Look at the annular ligament and quadrate ligament. The proximal joint is stabilized by the quadrate ligament, radial collateral ligament, and elbow capsule. The radial head maintains congruency within the proximal radio-ulnar joint with contribution from the annular ligament. Both the proximal and distal radioulnar joints provide rotational movement between these two bones. Therefore, any injury to the bony or ligamentous structures will hinder pronation and supination of the forearm and may result in a post-traumatic arthrosis at either articular surface. Look at the radial notch. The radius and ulnar form a concentric ring in the forearm stabilized by these three ligamentous components. Any injury to one portion of this ring may damage an adjacent ring component. In a Monteggia fracture, the bony injury to the ulnar is accompanied by rupture of the annular and quadrate ligaments with subsequent dislocation of the radial head. The injury can be associated with a comparatively high rate of complications. Radial head subluxation or displacement in this injury can place the surrounding neurovascular structures at risk. The radial nerve along with the branching posterior interosseous nerve lies directly adjacent to the radiocapitellar joint. A nerve palsy is seen in up to 10% of acute Monteggia fractures, Chen 1992. The injury can be associated with a comparatively high rate of complications. Radial head subluxation or displacement in this injury can place the surrounding neurovascular structures at risk. The radial nerve along with the branching posterior interosseous nerve lies directly adjacent to the radiocapitellar joint. A nerve palsy is seen in up to 10% of acute Monteggia fractures, Chen 1992. Look at the position of the posterior interosseous nerve adjacent to radial head. Numerous classification systems have been described, however, Vardo's classification, Figure 1, is the most commonly used. The four different types are based on the direction of radial head displacement, anteriorly, type 1, posteriorly, type 2, laterally, type 3, with an associated radius fracture, type 4. This classification was designed to help understand the mechanism of the initial injury and guide the reduction maneuver and cast position, Vardo 1967. In children, a type I anterior dislocation is most common, followed by type 2 lateral dislocations, Ring and Waters 1996. A modification of Vardo's classification was described specifically for children by Letts and Associates, Letts et al. 1985. 5 types were described with type A, B, and C subtypes of Vardo's type I anterior radial head dislocation. In Letts type A, the dislocation is accompanied by plastic deformation of the ulnar with an apex anterior deformity, figure. Type E is a green stick fracture of the ulnar, and type C is a complete fracture of the ulnar, figure. A Letts type D corresponds with a Vardo type 2, a Letts type E corresponds with a Vardo type 3. Acute injury diagnosis and assessment. Monteggia fractures are uncommon in childhood and can be easily misdiagnosed. Correct diagnosis and early treatment is essential to avoid elbow dysfunction and chronic dislocation of the radial head. An injury should always be suspected when a child presents with a painful elbow and limited motion after a fall. A child with a Monteggia injury will demonstrate pain, swelling, and possible deformity of the forearm and elbow. On exam, both flexion extension and pronation supination will be painful and limited. Obvious dislocation may be noted with careful palpation of the radial head. Palpation along the length of the ulnar will also be painful. If there is plastic deformation along the ulnar, a step-off may not be present. A careful neurovascular exam should be undertaken with special attention to the radial and posterior interosseous nerve. Although less common, median and ulnar nerve injuries have also been described, Lee et al. 2013. If the patient could not abduct thumb, A probable posterior interosseous injury should be considered. Hitchhike sign. It is essential to obtain radiographic studies of the elbow with true anteroposterior and lateral views. The most common reasons for missed Monteggia fractures are inadequate radiographs and inaccurate interpretation of the radiograph's Gleason end. BT 1994. With any suspicion of injury to the elbow, high-quality dedicated radiographs must be taken. To avoid missing a Monteggia fracture, several assessments should be made on radiography. The radial head must be carefully examined for congruency and alignment with the capitellum. A line drawn through the longitudinal axis of the radius should align with the capitellum on all radiographic views regardless of elbow position. In this radiograph, the axis drawn from the radial shaft is not intersecting the capitellum. Case courtesy of Bars Sarden, Barskent University Alanya Hospital. It is essential to obtain radiographic studies of the elbow with true anteroposterior and lateral views. The most common reasons for missed Monteggia fractures are inadequate radiographs and inaccurate interpretation of the radiograph's Gleason end. BT 1994. With any suspicion of injury to the elbow, high-quality dedicated radiographs must be taken. To avoid missing a Monteggia fracture, several assessments should be made on radiography. The radial head must be carefully examined for congruency and alignment with the capitellum. A line drawn through the longitudinal axis of the radius should align with the capitellum on all radiographic views regardless of elbow position. In this radiograph, the axis drawn from the radial shaft is not intersecting the capitellum. Case courtesy of Bars Sarden, Barskent University Alanya Hospital. Additionally, plastic deformation of the ulna is unique in children and should lead to careful scrutiny for radiocapitellar dislocation. The ulnar bow sign can assist in making the correct diagnosis. Lincoln and Mubarak 1994, DeGrief and Desmet 2004. On a true lateral plane radiograph of the elbow, the ulnar bow line is drawn along the dorsal border of the ulna from the olecranon to the distal metaphysis. The ulna normally has a linear border, and any deviation from this line may signify injury. When plastic deformation occurs, the location of maximum deformity is usually found to be near the mid-ulnar. Lincoln and Mubarak 1994. The goal of treatment in acute Monteggia fractures is restoration of the length and alignment of the ulna and reduction of the radiocapitellar joint. Usually, anatomic reduction of the ulna will reduce the radiocapitellar joint. Look at the radiograph. Dr. Baris from our institution reduced the ulnar fracture, and then radiocapitellar dislocation is also subsequently reduced. Case courtesy of Baris, Sargin. The rich vascular supply and periosteum surrounding the pediatric elbow contributes to a rapid healing response. It is critical to recognize and treat an acute Monteggia fracture before chronic misalignment occurs. If delayed beyond 1 week, a closed reduction of the radiocapitellar joint may no longer be possible. Ring and Waters 1996, High 2013. In acute Monteggia fractures, management depends upon the type of ulnar injury. Ring et al. 1998. With plastic deformation or incomplete fracture of the ulna, a closed reduction with cast immobilization is performed. Following closed reduction, the radiocapitellar joint can be reduced with a combination of elbow flexion, supination, and direct manipulation over the radial head. The elbow should be immobilized in 90 of flexion and full supination, Vardo 1967, K and Skaggs 1998. With complete fractures of the ulnar, there is a risk of displacement and loss of joint reduction after closed reduction and cast immobilization, Bolney and Menelaus 1989, Ring and Waters 1996, Nakamura et al. 2009. Operative treatment is necessary if stable reduction is not achieved. With a transverse or short oblique fracture, closed reduction with intramedullary wire/nail fixation is of the necessary. If fixation with an intramedullary wire/nail is not stable, a construct with plate and screws may be needed. Complete fractures with a long oblique pattern are more unstable and prone to collapse or shortening. Fixation with plate and screws is usually necessary to achieve stable fixation in this fracture pattern. Anatomic reduction of the ulnar usually allows stable reduction of the radiocapitellar joint. However, radiocapitellar joint reduction may be blocked by soft tissue interposition including the capsule, annular ligament, and/or posterior interosseous nerve. An irreducible joint warrants exploration, especially in the setting of a posterior interosseous nerve palsy, which may signify nerve entrapment, Rabeck et al. 2011, Ejondal and Hillen 2007, Lee et al. 2013. After fracture fixation, the ligamentous stability of the elbow should be assessed. Occasionally, the lateral ulnar collateral ligament is disrupted and requires open repair. Loss of reduction is important to recognize after acute treatment. Weekly re-evaluation following initial treatment allows assessment for recurrent radial head dislocation or subluxation. This is more common with isolated closed reduction of the ulnar. When promptly recognized, a repeat closed reduction with fixation is performed. In the acutely diagnosed Monteggia fracture, closed reduction with cast immobilization is the initial and preferred treatment for children. This can be accomplished with anatomic reduction of the ulnar, which generally provides a stable and anatomically reduced radiocapitellar joint. After a careful preoperative evaluation, longitudinal traction and reduction of the ulnar fracture is performed. The elbow is then flexed and direct pressure applied over the radial head guiding reduction. With the radial head reduced, the elbow is examined in pronation and supination to assess the most stable position. The elbow is then immobilized in approximately 90 of flexion in the most stable position of pronation or supination. Look at the very didactic case of Monteggia type 1 fracture. Notice the reduction of ulnar fracture with radiocapitellar dislocation. Case courtesy of Kamal Gokuz. After closed reduction and long arm cast application, accurate post-reduction radiographs are obtained. All views should demonstrate a reduced radiocapitellar joint. The patient then returns for weekly radiographic re-evaluation, including dedicated forearm and elbow series, for the FIRST 3 weeks following the manipulation. If the fracture alignment and radiocapitellar joint reduction are maintained, the patient returns at 6 weeks post-reduction for cast removal and a new series of radiographs. It is important to obtain radiographs of the forearm as well as true radiographs of the elbow. If anatomic reduction is not possible with closed treatment, operative treatment is indicated. With a transverse or short oblique ulnar fracture, fixation is attempted with an intramedullary nail. If the ulnar fracture is long oblique, comminuted, or unstable to pin fixation, plate fixation is performed. Occasionally the radiocapitellar joint is irreducible after anatomic reduction of the ulnar. Soft tissue interposition may be blocking the reduction, which may involve a torn annular ligament, an osteochondral fragment, or the posterior interosseous nerve. Open reduction and evaluation of the elbow joint is performed. An open lateral approach using the extended Cocker interval is performed. The radiocapitellar joint is visualized and examined for any interposed soft tissue. If the preoperative evaluation demonstrated a posterior interosseous nerve palsy, then the fracture is carefully examined for incarceration of the nerve. After removal of any soft tissue, the joint is reduced and checked for stability. The annular ligament is not routinely reconstructed, although it may be repaired, and a transcapitellar pin is not used since the radiocapitellar joint is stable if the ulnar fracture is anatomically reduced. After open reduction and ulnar fixation, the arm is immobilized for 4 to 6 weeks in a long arm cast. The arm is casted in 90 degrees of flexion, and the most stable position of pronation or supination. The patient is brought in for weekly follow-ups including dedicated elbow radiographs, for the FIRST 3 weeks after surgery, to ensure the joint remains reduced. Reconstruction for missed Monteggia lesion. Descriptions of surgical reconstructions for patients with chronic Monteggia lesions include annular ligament repair or reconstruction alone, ulnar osteotomy alone, combined ulnar osteotomy and annular ligament repair/reconstruction, and radial osteotomy. The relative merit of each surgical technique has not been well elucidated and is likely to vary by patient and lesion. However, almost every series advocates for an ulnar realignment osteotomy when reconstructing a chronic Monteggia lesion. The principal controversy revolves around whether an annular ligament reconstruction should be performed in addition to the ulnar osteotomy. Flynn J. Operative Techniques in Pediatric Orthopedics. Philadelphia, Walters Clower, 2015. The technique for open reduction of the radial head and annular ligament reconstruction in the setting of a chronic Monteggia fracture dislocation is attributed to Bell Tors. 2. This technique for radiocapitellar reduction in chronic Monteggia lesions employed the Boyd approach and reconstructed the annular ligament by turning down a strip of triceps fascia. Our overall approach for surgical treatment of chronic Monteggia lesions includes an open osteotomy of the ulnar with plate fixation, open reduction of radiocapitellar joint, and repair or reconstruction of the annular ligament. To avoid potential complications of posterior interosseous nerve injury and compartment syndrome, the reconstruction is performed via an extensile posterior approach that permits identification and protection of the posterior interosseous nerve and prophylactic forearm fasciotomies. There are surgeons who advocate extra-articular osteotomy of the ulnar alone, including use of external or intramedullary fixation of the ulnar. The morphology of the radial head and capitellum should be evaluated on plain radiographs and, if necessary, on MRI to define the concavity of the radial head and the reducibility of the proximal radioulnar joint and radiocapitellar joints. A normal concave radial head articular surface and normal convex capitellar articular surface are requirements for reconstruction. Three-dimensional imaging in children with radial head dislocation more than 3 years from injury can reveal flattening of the radial head and even development of a dome-shaped deformity. Corresponding flattening of the lesser sigmoid notch can also be observed. Preoperative elbow flexion extension and forearm supination pronation should be measured and recorded. General anesthesia is preferred over a regional block to allow postoperative assessment of peripheral nerve function and compartment syndrome. The patient is placed in a supine position on the operating table with the elbow, forearm, and hand outstretched onto a hand table. The entire upper limb including the axilla should be included in the surgical field. A sterile pneumatic tourniquet is employed to maximize access to the upper arm, which is required for the extensile surgical approach. One of two surgical intervals, the Boyd, extensile posterior, or the Cocker, posterolateral, can be employed for open reduction of the radiocapitellar joint and repair or reconstruction of the annular ligament figure. Either approach can be extended distally along the subcutaneous border of the ulnar, which can be exposed in the interval between the extensor carpi ulnaris and the flexor carpi ulnaris. Flynn J. Operative Techniques in Pediatric Orthopedics. Philadelphia, Walters Clower, 2015. An extensile curvilinear posterolateral incision is planned, see Figure A. The midportion of the incision permits access to the radiocapitellar joint through the Cocker interval, defined as the interval between the anconeus and the extensor carpi ulnaris. The incision can be extended proximally, which allows identification and decompression of the radial nerve, and harvesting of the triceps fascia is required for annular ligament reconstruction. The incision can be extended distally toward the subcutaneous border of the ulnar for the ulnar opening wedge osteotomy. The ulna is exposed between the extensor carpi ulnaris and the flexor carpi ulnaris. Initially, only the proximal and mid-portion of the incision is opened. Flynn J. Operative Techniques in Pediatric Orthopedics. Philadelphia, Walters Clower, 2015. The radial nerve should be identified between the brachioradialis and the brachialis and can be traced distally as it bifurcates into its sensory and motor, posterior interosseous, branches. As noted earlier, the posterior interosseous nerve can be adherent to the anterior elbow joint capsule, which itself is distorted by the dislocated radial head. Identification of the posterior interosseous nerve allows for its protection during joint reduction and annular ligament repair/reconstruction. In the midportion of the incision, the interval between the anconeus and the extensor carpi ulnaris is then developed. If necessary for visualization, the extensor supinator mass can be elevated off of the anterior lateral epicondyle and lateral supracondylar ridge as a single soft tissue sleeve. Placement of marking sutures will facilitate anatomic repair of the extensor supinator origin during closure. The elbow capsule is incised anterior to the lateral ulnar collateral ligament to preserve the integrity of lateral ligamentous complex and ulnumeral stability. Inspection of the radiocapitellar joint is initially obscured by fibrosis and synovitis. The radial head is typically dislocated anteriorly with a wall of anterior capsule and annular ligament blocking reduction. Pulvinar and synovitis are carefully debrided from the radiocapitellar joint to permit visualization of the radial head, annular ligament, and capitellum, see figure. The lesser sigmoid notch should also be thoroughly debrided to permit reduction of the proximal radioulnar joint. Thorough debridement of this region is critical to anatomic joint reduction and stabilization. Flynn J. Operative Techniques in Pediatric Orthopedics. Philadelphia, Walters Clower, 2015. Protection of the posterior interosseous nerve is necessary during joint debridement. Although tedious, the annular ligament can generally be identified. The central aperture of the annular ligament may not be readily appreciated, but careful dissection and dilation of its aperture allows reconstitution of its typical ring shape. Dilation is performed by making small radial incisions extending from the center toward the periphery. At this stage, a decision must be made about whether the native annular ligament can be salvaged. The native ligament is generally usable. If the annular ligament cannot be reduced over the radial head, the ligament may be incised along its posterior insertion, at or adjacent to the posterior rim of the lesser sigmoid notch, and repaired following reduction of the radial head. In general, annular ligament repair or reconstruction alone does not result in a congruent, stable radiocapitellar reduction due to the deforming force created by concomitant ulnar malunion. An opening wedge osteotomy of the ulnar is normally required. Some surgeons only perform an extra-articular reconstruction with ulnar osteotomy, and not routinely obtain an open reduction of the radiocapitellar joint or perform an annular ligament reconstruction. The ulna is exposed in the extensor carpi ulnaris flexor carpi ulnaris interval. Osteotomy of the ulna is planned at the apex of the malunion. When the ulnar injury is characterized by plastic deformation, the osteotomy can be made proximal to the apex and closer to the elbow to more effectively correct of radiocapitellar malalignment. Fluoroscopy is used to localize the site of the intended osteotomy, and a subperiosteal exposure is obtained. An oscillating saw is used to create an osteotomy with preservation of the far cortex. Copious irrigation with saline is used to minimize thermal necrosis. A laminar spreader is used to create an opening wedge. Partial overcorrection of the ulna is suggested to avoid late radial head dislocation. Temporary pinning of the radiocapitellar joint can help determine the size of the opening wedge osteotomy. In this technique, the radiocapitellar and proximal radioulnar joints are anatomically reduced. A smooth 0.045 to 0.062 inch Kirschner wire is temporarily inserted across the radiocapitellar joint to stabilize the reduction. Anatomic reduction of the radial head allows the ulnar osteotomy to open the necessary amount to maintain the reduction. When the radial head is anatomically reduced, the ulnar osteotomy is provisionally stabilized with appropriately contoured plate and screw fixation, see figure. We typically use double-stacked 1/3 tubular plates in younger patients and a 3.5 mm dynamic compression plate in larger patients. Synthes, Westchester, Pennsylvania. The temporary Kirschner wire is removed. Further testing under direct visualization and fluoroscopy is performed to confirm that the correct angle and degree of osteotomy was selected for maintenance of radiocapitellar and proximal radioulnar joint alignment. If correct, the fixation is completed. 4 to 6 quarters of fixation should be achieved proximal and distal to the osteotomy site. See figure. If available at the malunion site, fracture callus and periosteal bone can be used for local graft after completion of the osteotomy. Periosteal repair is performed to expedite bone healing. As mentioned, an alternative to plate and screw fixation is external fixation. External fixation can be used with an acute opening wedge osteotomy or by gradual lengthening and angulation. Flynn J. Operative Techniques in Pediatric Orthopedics. Philadelphia, Walters Clower, 2015. Open reduction of the radiocapitellar joint. If necessary, repair of the annular ligament is completed through ulnar periosteal tunnels with braided 2-0 polyester suture, Ethibond, Ethicon Incorporated, Somerville, New Jersey. If the annular ligament can be salvaged, the reduction of the radial head is evaluated with fluoroscopy. If there is anatomic restoration of radiocapitellar alignment, annular ligament repair, or reconstruction, alone may be sufficient. This is very unusual, and typically, ulnar osteotomy is required. If the annular ligament cannot be salvaged, its remnant is sharply excised in preparation for subsequent annular ligament reconstruction, usually with a strip of triceps or extensor supinator fascia. Annular ligament reconstruction. In the author's opinion, annular ligament repair or reconstruction is indicated. This involves either suture repair of the reduced annular ligament to the proximal ulnar or, if an annular ligament repair is not feasible, use of local fascia for reconstruction. Although this is supported by many surgeons, several investigators report success with isolated ulnar osteotomy. Sufficient evidence does not exist to demonstrate a clear advantage to either approach. A strip of triceps fascia may be used to perform an annular ligament reconstruction. While preserving its attachment to the olecranon, an 8 cm strip of the central triceps fascia is elevated off the muscle in a proximal to distal fashion, all the way to the level of the radial neck. The extensor supinator fascia may be used as an alternative. Often, periosteal repair is sufficient in the young child. Seal and Peterson advocate use of 2 crossing drill holes in the proximal ulna placed at the anterior and posterior margins of the lesser sigmoid notch. Although this procedure increases the technical difficulty, the resulting reconstruction may prevent the more posteriorly directed force that can occur with the Bell-Tors technique. See figure. Schematic representation of annular ligament reconstruction techniques. A. The Bell-Tors reconstruction, which results in a posteriorly directed force. 2b. The technique suggested by Seal and Peterson. In this technique, crossing drill holes are created at the anterior and posterior rim of the lesser sigmoid notch. The resulting reconstruction may improve stability of the radial head. Adapted from Seal M.J., Peterson Ha. Management of chronic post-traumatic radial head dislocation in children. J. Pediater Orthop 1999 19 to 306 to 312. Flynn J. Operative Techniques in Pediatric Orthopedics. Philadelphia, Walters Clower, 2015. To facilitate annular ligament reconstruction using the Seal and Peterson technique, we recommend provisionally suturing the triceps fascia and using a wire loop for suture passage. Overtensioning of the reconstruction should be avoided in order to prevent notching of the radial neck in the long term. Direct visualization. Limited prophylactic fasciotomies of the volar and dorsal compartments are performed to minimize risk of postoperative compartment syndrome. Prophylactic fasciotomies have the secondary advantage of facilitating periosteal closure. Postoperative care. Following wound closure, a bivalved long arm cast is applied, typically with the elbow in 80 to 90 degrees of flexion and the forearm in 60 to 90 degrees of supination to maximize stability of the radiocapitellar and proximal radioulnar joints. All children should be admitted overnight for pain control and neurovascular monitoring. Casting is discontinued 4 to 6 weeks after surgical reconstruction, and children are transitioned to a protective long arm splint for an additional 3 to 4 weeks. Splint removal for active motion, particularly forearm rotation, is important. Formal rehabilitation is initiated and maximal recovery is anticipated at 6 months. Elbow flexion and extension return more rapidly than forearm rotation. Complications. Restricted elbow or forearm motion, particularly pronation. Postoperative compartment syndrome can occur. Routine perioperative neurovascular monitoring is recommended for early detection. Pain out of proportion to examination or increasing narcotic requirements represent early signs of compartment syndrome and should prompt immediate evaluation. Prophylactic intraoperative forearm fasciotomies are advocated to lessen the risk. Posterior interosseous nerve palsy can occur following reconstruction. If the nerve was identified and protected during surgery, expectant management is recommended. Serial clinical examination will demonstrate an advancing tidal sign and progressive return of motor function. Failure of recognizable clinical recovery by 6 months is a relative indication for surgical exploration. Complications. Ulnar nerve palsy can occur with extensive lengthening of the ulnar and may be an indication for decompression. Recurrent subluxation or dislocation of the radial head does occur and negates the original purpose for surgical reconstruction. This is not an operation for the uninitiated. Notching of the radial neck if the annular ligament reconstruction is too taut. Ulnar non-union can occur. An incomplete hinged osteotomy, supplemental bone grafting, stable fixation, and periosteal repair lessen the risk. Thanks for watching my video. Do not forget to subscribe to my non-profit YouTube channel.